What's up, guys? Today's Tuesday. What that means is it's BFR Tuesday, just like Taco Tuesday, just like, thank God it's Friday, I don't know. But Tuesday means it's BFR time, and my name's Cara. I'm here to answer some questions. Sorry about the riffraff behind me. We just moved into a new office last week, so we're getting all organized and settled. Don't mind the cursing in the back. Double check safety back there. But anyway, so I want to first start off with answering any questions that anybody has regarding BFR. You can just post that in the chat section. So I'm going to first post like hello from Dallas. Hi Abe, how's it going? Then I'm gonna talk about. I'm gonna answer questions first, and then if we don't have too much, then I will go into a new study that I found, and I'm uploading right now into the handout section. If you want to take a look, it's clinical applications for BFR 2021. Just kind of an update. All right, so chats. Can you talk about some limitations of BFR? Sure, happy to. From a limitation standpoint, of course, we have our contraindications, patients that are just not good candidates, people that have excessive clotting, they have high hematocrit levels, maybe that's due to hormone replacement therapy, people that are at higher risk for clotting. Those are going to be your biggest contraindications. And then, the limitations are ultimately high intensity training for strength will always trump. And when I'm defining high intensity training, some people think I'm saying high intensity interval training or HIIT training. I'm not. I'm talking about loads that are between 65 and 90% of your 1 rep max, so heavier loads. If we compare BFR and light load to high intensity or heavy load training is always going to win in the long term for strength. In the short term, you'll see greater adaptations with BFR and light intensity training, meaning that at about 2 or 3 weeks, we'll start to see strength occur. Whereas with high intensity training alone, we will see neurological adaptations in the first 30 days, but not true strength for 12 to 16 weeks. For hypertrophy, you're going to see faster gains and probably better gains with BFR. So we have to kind of separate size versus strength and really looking to see what kind of outcome you're looking for. Use the end goal in mind. Am I trying to get stronger? Am I trying to get bigger? Am I trying to do both? Can the person do high intensity training? And if they can lift 65% of their 1 rep max, I would have them do that as much as they can, and then use BFR as a supplement, like complementary BFR training after their workouts, doing a little bit of supplemental work, and do like a all the way to fatigue type 1 or 2 exercises. Like let's say I wanted to work on my bicep size, I do my normal CrossFit workout, then I might do 1 or 2 exercises for my bicep 2 or 3 times a week to radically increase my hypertrophy in those areas. So I would say those are the biggest limitations. Contraindications, number 1. And number 2 is that if you can lift high intensity, you should always try to lift more high intensity and not have BFR be a total substitute for those folks. Diabetes and obese patients. For obese patients, it's harder to get the pressures because the limb is so much larger, typically. So you're going to need to use higher pressures with them. They tend to not be able to tolerate the discomfort, and that's a limitation too, as well, is that it is not the most comfortable exercise in the world. And so it's not for everybody. So some patients will want to be, or if they're not used to exercise, if they're not willing to have a little bit of discomfort to achieve what you're asking them to do, then that is a limitation. And that's why I recommend doing a 2-week on-ramp program with folks, doing like lighter loads, lighter pressures, gradually increasing the volume over time so people can get used to it. Literature suggests it takes about 3 sessions of BFR in order to get your body used to using the cuffs and lifting weights. So, give yourself a little bit of time and give them a little bit of time as they're gradually increasing loads and volume. I can't think of any other limitations. Does anybody else have any limitations with BFR that they can think of? They can just type that into the chat section. For diabetes, for one, I would, and this is with everybody, not just people with diabetes, but I would make sure that they've eaten prior to training. If somebody comes in on an empty stomach and I have them do like a isometric hold, so sometimes I'll have people do, especially for like a patellar tendinopathy, I'll have them do like a decline board wall sit for 1 to 2 minutes. And I've had people get pretty close to passing out on me if they haven't eaten. So make sure that those people have a little bit of food in their system, and then that way it won't be such a large stress. You're not going to use BFR in order to try to burn a bunch of calories and lose weight and do it on an empty stomach. Do it as they've eaten, and they'll be more comfortable, more likely to do more training if you do it that way. Jared, does that answer your question? And also, Antonio, does that answer your question? Let's see. So I'm reading Abe's. Long story short, ex-wife is a recipient of the first bone transplant after a bone cancer situation over 20 years ago. She's atrophied and has a limp. At this point, is it too late? No, I don't think it's ever too late. I think, we have seen people adapt to resistance training as old as 85 years of age. So I don't think it's ever too late. I don't think we should ever give up on anybody. Physically, the body is amazing. I think that you can create, we have to have the mindset of 1% better. Do I expect her to have the same adaptation as a healthy, young, college age athlete? No, of course not. But I think that it's never too late. I've used BFR with post-stroke, people that can't walk more than 4 or 5 minutes without stumbling and falling, and been able to increase that up to 20, 25 minutes, which greatly improved his quality of life. So don't give up on it. I would start it low and put the work in, and the body will adapt. Vertigo. So Jared, vertigo depends on where it's coming from. I mean, most of the time in my clinic, when people are complaining of vertigo, it's an inner ear problem. They might be having congestion through the lymphatics of the sternocleidomastoid, whether it's superficial or deep. Me being a chiropractor, I typically will check their upper cervical, because sometimes malalignment of the upper cervical vertebrae will cause congestion, and so fluid gets stuck above the eustachian tube and it's not able to drain, and that can cause vertigo. You really have to sort out what the vertigo is from for me to give you a better answer, because there's so many different causes. But if it's inner ear vertigo, I'm not looking at BFR as my primary source of resolution. I'm going to be looking at, hey, does the neck function and move well? Are these muscles under control? Are they constantly in a forward head position where they're looking down? And so they're constantly tightening these. And do we need to do things like chin tucks like this to get better alignment and get everything back? And so we're not putting so much stress here, so we can't get flow down into into the lymphatic system. I always check for inner ear infection with vertigo. There's a few tests that I do. And then there's a few maneuvers that you can look up, like a modified Hall Pike or a modified Apley's maneuver. But again, it's really dependent. Some of it can be a viral infection. Some of it can be medication-based. It would have to be a full workup to truly understand where it's coming from. Any other questions or concerns, anything like that? And I also wanted down here, let everybody know that if they go to BFRUniversity.com, it's a new website that I just put out, and you can sign up for, I think it's bi-weekly newsletter where I'm taking, interesting articles and journal publications and putting it in there and just sending it out to my list. And you can sign up for that and get on that list as well. I think everybody on this webinar list got put on there as well. So that should have gone out today, I believe, but you should expect something about every 2 weeks, just on anything that's interesting that I stumble across. All right, if you go to the handout section, you'll notice that I downloaded a recent article on clinical aspects of BFR. It's just some things that I wanted to highlight. So I'm going to share my screen, and I'm going to kind of take you through some things that I highlighted. All right, so screen is shared. All right, so hopefully you guys can see this. And this was an open source publication, so I was able to put it into the notes and share freely without violating any copyright limitations. All right, so this study was really a review. It's looking at the current clinical concepts, but I think it applies to pretty much everybody. This was written by Dr. Lorenz in Lawrence, Kansas. And he kind of goes through and he talks about some of the highlights about BFR, and also the, again, some of the limitations and some other things. So I just highlighted a few things in here. Really what BFR is, which is the use of BFR training offers the ability to mitigate weakness and atrophy without overloading healing tissues or tissues that can't take the heavier loads. The risk for injury or adverse event is thought to be consistent with traditional exercise models. As long as we're utilizing appropriate training parameters, which is really what I'm here trying to teach. There's some evidence that BFR can improve function and pain outcomes beyond traditional resistance training, meaning like decreasing pain in osteoarthritis, like of the knee. It's been very effective for me in patients with osteoarthritis pain. We should be utilizing exercise early on in our rehab. Or efforts to mitigate weakness should start early, is what the authors alluded to and stated. The use of low load BFR training typically results in more positive adaptations, meaning increased strength or cross-sectional muscle area when compared to work match low load resistance training, but results are mixed when compared to higher load resistance training. What does that mean? That means if I take a 5-pound dumbbell and I do the same amount of reps with and without BFR, my BFR side is going to adapt much greater than the non BFR side. What has been shown is that low intensity training, meaning weights between 20 and 35% of your 1 rep max, don't really cause strength and hypertrophy change. So when we add BFR to the equation, that's when we start to see adaptation. But with that said, we also need to incorporate high intensity training when we can, because the adaptation effect over time is going to be better using high intensity training. So they say, well, why not just use high intensity training all the time? Well, not a lot of people, and so, I should say, a lot of people can't tolerate high intensity training. So we have to have a bridge. We have to be able to bridge the gap between low intensity training and high intensity training. And that's why BFR is so valuable in the rehab setting, because most of my patients that come in with a muscle strain, rotator cuff tendinopathy, they can't lift heavy loads. And so I'm going to use the lighter loads until they can with BFR. Many mechanisms, they go into kind of the proposed mechanisms. My primary feeling right now at this point, 6 years into this journey, is that it's using hypoxia or lack of oxygen creates pre-fatigue in the muscle, and that creates a myriad of adaptations from the body and allows patients to adapt. Safety considerations. I highlighted no definitive timeline post-surgery. I have some patients that can start day one with like post-ACL if they have any increases in risk. Understanding that everybody's at an increased risk. There's 100x increased risk after orthopedic surgery for blood clots. So we have to understand that there's also an increased risk without BFR post-surgically because of the time that the tourniquet was on the limb. So just use that. If they have pre-existing clotting factors and things, you're going to wait 2 to 4 weeks before using BFR. The other thing you're going to wait after surgery is any large incisions. So incisions larger than 2 inches, I'm going to wait for until that incision is fully closed and healed before using BFR, because BFR may blunt that healing process of the tissue. Safe and effective BFR application requires a clinician to assess various elements of the treatment process and device. And it's not just the clinician. If you're using this on yourself, you want to be using devices and procedures that are safe and have efficacy. You want to be concerned about cuff width and placement, pressures, and the devices selected. So using a wider cuff appears to be safer and more comfortable. Using that allows you to use less pressure. You want to be using things that go all the way around the limb, not partially. Cuffs that are medical grade, that are not like a voodoo floss, or things that you can't control the pressures, are highly recommended. In general, we use 40 to 80% of arterial occlusion pressure. And so we want to be able to establish that occlusion pressure, whether you're using an external Doppler or you're using something with an internal device like a Delphi unit or a Smart Cuff Generation 3 unit, something that will measure those pressures for you. I'm tending to use more like 60% in the lower extremity, and I'm tending to use between 40 and 50% on the upper extremity. I'm still sticking to the 30, 15, 15, 15 repetitions with most of my people. That requires that you use a light enough load that's going to be in that 20 to 30% range, 30-second rest in between sets, or interset rest. And you guys can read through the rest of this. This is all kind of stuff that it's all the stuff that I teach and that we teach in our Smart Cuff classes. And I like to review these to make sure that I am consistent with what the evidence and the literature is suggesting, and other like-minded folks in the clinical space. So I wanted to share that with you. You can download that and give it a read. And I'll unshare I'm going to unshare. All right, so let's see, what other questions do we have? What's the recommended pressure, the cuff to be inflated? I think I just went through that. 60% in the lower extremity, 40 to 50% in the upper extremity is about right. Demetrius, tendonitis and tendinopathies and tendinoses, I use a lot. You can do it 2 different ways. There's some evidence. There's been one study that I know of. I haven't seen it validated yet, but it needs to be. Because here's the concern from a tendon standpoint. Tendons take longer to adapt than muscle. So if we have early adaptation in the muscle, 4 weeks, is that enough adaptation time for the tendon. Well, 2 years ago, I would have said, no, I don't think so. I think you're gonna require the tendon to take more time to catch up. It's analogous to taking anabolic steroids. Muscle would grow, but the tendon wouldn't have time to adapt, and then you'd have tendon failure and ruptures because the muscle was too strong for the tendon because the tendon didn't have enough time to adapt. Well, then a study came out last year, the author is escaping me right now, and it looked at that tendon size and the tendinocytes that were produced with BFR, and it appeared to be equal to the myocytes that were produced. So what that means is that the adaptation of the tendon was equal to the adaptation of the muscle. So there was nothing to be concerned about, and the tendon will adapt. So if you have a tendinopathy, I would train it just like you would without BFR. So let's say you have a lateral epicondylitis, tennis elbow is a common term. My first exercise for tennis elbow is using rubber bands around the fingers and doing, rubber band exercises. Very light loading. I could do that with the cuff on, and then the patient would do that at home without the cuff. Then I might do an isometric hold, and I'll do an isometric hold with a dumbbell, keeping the wrist in neutral and put the cuff on. Great. Then they can replicate that at home. Then I would do an eccentric loading with the cuff on. Okay, so you can replicate all the same exercises that we use without the cuff, but now we're going to get the physiological adaptation that we normally would not expect with light load training. Last week I was taking a very seriously strenuous tennis lesson, didn't feel any pain. All of a sudden I'm buckling more than usual. Why would that be? The strenuous, your body's not really ready for it, and it's got to be adapted to it. So I would recommend loading the joints with some plyometrics, like dot drills and ladders and other things to get the speed in. So then that way your body can adapt to the speed and the strain of what you're asking. Capacity and demand is always a thing. We've got to have the capacity to take on the demand that we're being asked of the body. All right, 1:25. I am up against the time because I've got patients coming in. One last question, if anybody has it? All right, thank you so much for joining me today. What about using BFR with cardio? Yeah, go back on my YouTube channel and you'll see aerobic training with BFR. You can do walking, you can do cycling, you can do steady state, you can do sprinting. You can do a whole variety of different types of training and programming with when BFR. It depends on what you're asking and what you want your body to do. Early stage rehab, I just have people walk outside or on the treadmill with the cuffs on, and you're going to get adaptation of increased strength of the lower extremity and VO2 max increases within, depending on how often you're training, 5 days a week, you can see that as early as 3 weeks. We saw that in Division I basketball players, 15-minute training. I believe they did it twice a day for 3 weeks, and they saw adaptation effects. So pretty low intensity, still got adaptation effects. Abe, when are my cuffs coming? I don't know. Send an email to sales@smarttoolsplus.com. I don't handle any of that. I handle the education and programming. I know that they said that they got new boards in, and they should be assembling and getting those out by the middle of this month, and we should be all cut up by the end of this month. So it depends on when you order it, is my guess. All right, thank you guys so much for joining. If you haven't joined yet, go to my YouTube channel, Cara, or BFR University, and you can sign up for my bi-weekly newsletter there for more information and education around BFR. Thanks so much, and have a great week. Bye for now.